All right. Good evening, everyone, and welcome to today's webinar on male infertility. My name is Irina MacArthur, Director of Patient Experience, and I'm honored to introduce you to two remarkable experts in the field, Dr. Ali Domar, our Chief Compassionate Officer at Inception Fertility, and leading psychologist specializing in the mind-body connection, and Dr. Steve Sadik, a reproductive endocrinologist and infertility specialist. Tonight, we will be diving into often overlooked topics on male infertility, offering valuable insights and guidance to support couples on their fertility journey. I would like to mention that we will be addressing all of your questions during our Q&A session at the end of the webinar, so feel free to submit your queries as we go along. Thank you very much, and I look forward to discussion.
Thanks, Irina. So, Dr. Sadik, do you want to share your slides?
Sure, absolutely. All right. Can you see my screen?
Yeah, can you do slideshow from the beginning?
Will do.
There you go.
All right. So I'm Steve Sadik. I'm one of the reproductive endocrinologists here in Center for Reproductive Medicine in Orlando, and I'll be talking today about male factor infertility. So if you look at the different causes of infertility in couples, about 30% is caused by women, about 30% is caused by male factor, and 40% is a combination of both. For female patients, there can be tubal disease, there can be adhesions, obstruction, there can be hormonal issues or diminished ovarian reserve, and PCOS and endometriosis. For the male patient, there can be varicocele, there can be an infection, there can be an obstruction, or even a hormonal or a immunological imbalance that is affecting the sperm count. So as an introduction, just when should couples start seeking fertility assistance or fertility treatment? And so if the female is younger than the age of 35 and the couple have been attempting to conceive for over a year, then that should be a point where the couple seek fertility assistance. And if the couple is above 35 and have been attempting to conceive for over 6 months, then that also is a point where the couple should seek fertility assistance. And just as a broad statistic, 1 in every 8 couples between the ages of 31 to 37 have infertility or are diagnosed with infertility, and 1 in every 4 couples above the age of 38 are diagnosed with infertility. And as you can see, as we get older, it just gets harder to get pregnant. The fertility rate of men and women both start to decline. For women, it starts a little bit earlier, around the age of 32, where the egg count starts to decrease. But for men above the age of 45, the sperm count is also affected. So not only the number of sperm, but how fast they move and how well they fertilize the egg. And so for initial evaluation for a male and female patient, for the female, we do lab work, and that includes a hormone panel looking at FSH, LH, estrogen, and AMH, and other hormones that could also potentially affect pregnancy. And there's also, we do a uterine evaluation that includes looking at an ultrasound to look at the uterus, but also doing something to look at the inside of the uterus. That could be either a sonohystogram or a hysterosalpingogram. And the sonohystogram takes a look at the inside or the cavity of the uterus. The hysterosalpingogram assesses the tubes, sees if they're open. For the male side, there's less tests, and you get faster results, but the initial part of it is a blood work, also looking at testosterone, hormones produced from the brain, and even estrogen level in men, but also looking at a semen analysis. So the semen analysis, one second, I apologize. So the semen analysis looks at the sperm count and the sperm function. And also, if need be, they can do ultrasounds on male and even genetic carrier screening for the male. So what is a semen analysis? A semen analysis looks at the volume and the quality of the man's sperm. It is initially the first step that is used to help detect male fertility issues. The test also shows whether a vasectomy is successful. So if a patient or a male patient has undergone a vasectomy, then it is another test to see if that vasectomy has worked or not. The semen analysis involves collecting sperm or a semen sample, and it's evaluated in the lab. Usually most clinics collect in the clinic, but nowadays you can actually collect at home and drop off the sample within a time frame. So what is sperm? Sperm is the male reproductive cells, and they have a unique shape. They have a head, a body, and a tail. And the head is what contains the genetic material. The tail allows the sperm to swim through the reproductive canal and reach the egg and fertilize it. And the body has the actually energy for the head for the sperm to swim. The sperm is also surrounded by semen, which is fluid, which makes it possible to deposit the sperm in the reproductive tract. This fluid also contains proteins, vitamins, and minerals that help fuel the sperm's journey to the egg. So what do we look for in a semen analysis? We look at, firstly, the volume, and we look at the pH. We also look at the amount of semen or sperm in the sample in milliliters, and the concentration is usually per milliliter, so that's an important number, how many sperm per milliliter of semen collected. We look at the shape of the sperm, the morphology, so the size, the head, if it looks normal. We also look at the motility, how fast they're moving, if they're moving normal, or if they're swimming around in circles. And we also look at the time to liquefaction, which is to assess how fast the sperm turns from a sticky substance to a liquid. And if need be, sometimes we even assess vitality. So there are some occasions where the sperm itself in a sample might not be moving. And in that point, we have to check to see if the sperm is alive or dead. And that's what vitality is. And finally, we also check to see the white blood cells in the semen analysis. That may indicate an infection or inflammation in the sample. So then these are the normal values. The pH has to be alkaline, so above 7.4, and a normal sperm in a count and ejaculate can range from between 39 million up to a billion. The volume, usually we want at least 1.5 ml, and the total motility or the motility of the sperm, we like at least 40% of the sperm to be motile. The main sign of a low sperm count, or the main symptom, is the inability to conceive a child. That's usually when we diagnose as low sperm count. And in some men, this may be the first sign of an underlying problem. There may be some chromosomal abnormalities, some hormonal imbalances, some varicocele veins, which are dilated veins that surround the testes. And sometimes there may be conditions that block the passage from the sperm from the testes or where they're stored to the outside world. And other symptoms may be also sexual function. So if there's difficulty with sexual drive, maintaining an erection, or difficulty with the ejaculation, sometimes even when there's painful swelling or a lump in the testicular area, that may be also another sign of low sperm count. So what are medical causes of low sperm count? So the first one, more common one, is a varicocele. A lot of men have varicoceles and they go by undiagnosed or asymptomatic. These are the veins that surround the testes, and testes are usually contained outside the body. They like a cooler temperature compared to what your body's temperature is. When those veins get dilated, they heat up the testicles. And so what that causes is it can cause a lower sperm count, an abnormal morphology, and even it may slow down the sperm. So it is one of the causes of infertility, but the exact, and sometimes fixing it may help increase the sperm count. And so if there is a varicocele, it can be diagnosed and it can also be treated. Sometimes also infections can interfere with sperm production. Certain infections can increase testicular damage, but at the end of the day, most of the time, even with an infection that has caused like a blockage or inflammation, sperm can usually be still retrieved. Other problems with, or other causes of low sperm count is ejaculation problems. Whether there's retrograde ejaculation, meaning instead of the semen entering the normal reproductive tract, it goes back into the bladder. And that sperm can also be retrieved normally after, let's say, a specimen attempt collection. We get the patient to empty their bladder and we collect the sperm that way. And there are various ways that we can test for it. Also, occasionally, some injuries, some spinal cord injuries can also cause retrograde ejaculation. And certain medications can also cause ejaculatory problems, such as blood pressure medications. So this is why it's important to get a thorough history from the male partner to make sure there's nothing else going on that is causing infertility or causing the low sperm count. Other tumors can also cause lower sperm count, especially tumors in the reproductive tract. One of the signs of testicular cancer can be a low sperm count that is only diagnosed with infertility. And so that's why when you diagnose a low sperm count, it's important to do a physical exam, a thorough exam, to make sure there's no organic cause or no medical cause for that sperm count. And also a history of undescended testicles. Typically during fetal development, the testes descend and into the sac and or the scrotum. And so if there were issues in childbirth where one of the testes didn't descend and it has to be repaired with surgery, that can also affect sperm count in the future. There are also certain chromosome defects. Now, I'm not going to discuss into detail, but the main basis of these chromosome defects is a mutation in the Y chromosome. So men have an X and a Y, or a male have X and Y chromosome. And the Y chromosome has most of the genes that are responsible for sperm production. If there's a mutation in the Y chromosome, whether it be an extra piece of mutation or a missing part, that can affect the sperm count. And once we see a very severe or very low sperm count, the Y chromosome, doing genetic testing and testing the chromosomes is an important test to do. Also, very commonly using testosterone or anabolic steroids. These act very similar to birth control in men, and they significantly reduce the sperm count. Even after you come off those medications, it may take a long time for the sperm to recover and start to produce sperm. And most men who end up using testosterone for long term will end up requiring fertility treatment to help them conceive in the future. So what are other causes? We talked about anabolic steroids or steroids in general, but also using drugs. Marijuana and cocaine may affect the sperm count, may reduce the quality, but also may affect ejaculation and the male sexual function. The same with drinking alcohol. Drinking a significant amount of alcohol can also lower testosterone and also decrease sperm production in the testes. Certain occupations can also affect sperm count, whether it's trucking or being exposed to certain chemicals or radiation. Those can also affect sperm count. And also men who smoke cigarettes or tobacco can affect their sperm count, quality, and how fast they move. But it also can negatively affect the partner's pregnancy. And also environmental stress, even though stress is something that is very hard to subjectively measure, emotional stress or even stress during infertility can affect sperm count and can affect the ability to conceive or even sexual function. And that also includes depression. Depression, whether it is treated or untreated, can affect sperm count negatively. And weight, obesity can also impair infertility in several ways, which leads to directly impacting the sperm and causing hormonal changes that may reduce infertility. That can also include an increased risk of diabetes, and diabetes can also negatively affect sperm count. How to go about improving your fertility? So the first and foremost, don't smoke. cutting back on alcohol as much as possible. If you're drinking in the excess of more than 3 drinks a week, it is recommended to cut back not only for sperm count, but for your health. And obviously staying clear of illicit drugs. Marijuana, like we discussed, can affect sperm count, and it takes a while for the effect of marijuana to be reduced in terms of sperm count. Maintaining a healthy lifestyle, eating healthy, exercising, avoiding excess heat, so not staying in a sauna for too much or hot tubs, and avoiding chemicals or toxins that are known to affect, or as we call, endocrine disruptors. What are the treatments and therapies that we can offer? So the first one is very directed at varicocele. So if there's an obstruction, or if there's a varicocele, or if there's something that is causing a low sperm count, or physically causing a low sperm count, sometimes it can be repaired. If it's a prior vasectomy, it can be reversed. And sometimes when there is no sperm in the ejaculate, but we know there's sperm in the testes, a testicular biopsy may be done for that sperm to be retrieved and be used with fertility treatment. If there's an infection that is detected, we can always treat it with antibiotics, but that sometimes does not restore fertility, and a biopsy may be needed, or other methods of improving fertility may be needed. And there are also other medications that can help with reproductive functions, such as erectile dysfunction or premature ejaculation. But there's also some hormonal medications that can be used to help increase sperm counts. So there are medications that help boost internal levels of testosterone, leading to an increased level of sperm production. However, a thorough evaluation by your physician and a thorough evaluation by a reproductive urologist is needed before these medications can be prescribed. So we talked about the lifestyle changes, but for treatment for male factor, or for treatment in general for infertility, we mainly have 3 treatments, and the first 2 are kind of linked. So using fertility medication like Clomid and Letrozole and gonadotropins. So those for women help them ovulate. So if you're ovulating 1 egg a month, we try to get you to ovulate more than 1 egg, not too many, because that increases the risk of the twins and triplets. And at the same time, if it was just an ovulatory issue, we tell you when to have time dinner course. But if there's a sperm factor or a male factor, then we usually recommend doing an insemination, or an IUI, which is basically taking the sperm and putting it inside the uterus. Sometimes the sperm count may be too low, or we are unable to retrieve sperm in an ejaculate, and other methods are needed, and that includes IVF, ICSI, which is basically taking the sperm, fertilizing the egg directly, and potentially doing genetic testing. But also there are other options like third-party reproduction, which involves using donor eggs or donor sperm. So an IUI is just how it sounds, is an intrauterine insemination. Basically, the sperm is placed in a catheter, and that is injected inside the uterus. The sperm is usually washed and concentrated into a very small amount. And the theory behind it, or the hope behind it, is we get as many good sperm in the right place at the right time, and that increases the chances of pregnancy. The chances of pregnancy with an IUI vary significantly on 2 factors. 1 being the female age, or the female partner age, and 2, the number of sperm in the vial. The optimal number of sperm is anything above 10 million. But the least amount of sperm I would typically recommend is somewhere close to 5 million. Below 5 million, the chances of success decreases significantly, and it gets very close to somewhere between 4 to less than 1%, depending on the number of sperm in a vial. And so at that point, when it's below 5 million, that's when I typically recommend more or different treatments to increase your chances of success. And so the pregnancy rate usually after 3 IUIs plateaus at around 30%. And that's usually the number of IUIs I would recommend, or at least having 3 IUIs and then meeting with your physician and kind of talking about what happened in those cycles, what we can do to increase the chances, and if they were ready to move on another treatment. Okay. The next form of treatment is IVF. IVF, I usually like to describe it as a three-step process. And the first step is growing eggs. So every month, the female partner has a set number of eggs. We try to grow them all at the same time. And that takes about somewhere between 10 to 14 days. And then we do a procedure to retrieve those eggs. And that's called an egg retrieval. Once we retrieve those eggs, we can then fertilize the egg with the sperm. And let's say if the sperm count is below 5 million, then IVF would be the best modality for that treatment. And we take the sperm and we inject the eggs directly with the sperm, making sure that we pick the best sperm to fertilize those eggs. And that's the second part, and that involves incubating those embryos for about 5 or 6 days, sometimes even up to 7. And then at the end of that point, we would typically do genetic testing and freeze those embryos. And the genetic testing just tells us if the embryo is genetically normal, so if it has 23 pairs of chromosomes. And depending where you are, sometimes you find out if it's XX or an XY embryo. And but you can also do specific genetic testing for specific genetic diseases. And that includes cystic fibrosis, sickle cell, or thalassemia, but also a number of different genetic diseases. The third step is taking that embryo and placing it back inside the uterus. And that is the third step of IVF. Once we have a good quality embryo, we take it and put it back inside the uterus around the window of implantation. And each embryo we put back, if it's a good quality and genetically normal, has about a 50 to 60% chance of implantation. And this is just a picture of how we go about fertilizing the egg. And this is an egg here. This is just a needle that holds the egg in place. And this is the needle that has the sperm in it. And you can see the sperm being placed inside the egg and injected. So this process is called ICSI. And this helps significantly with male factor in IVF. And this is just to show you the success rate of IVF compared to IUI based on the female partner's age. Below the age of 35, the success rate of IUI is about 10 to 12% every month, up to 15. But with IVF, it can range between 50 to 60%. As the couple get older, there's still a difference in terms of success rate between IVF and IUI, but that gap starts to decrease, and that is mainly dependent on the female partner's age. The older the female partner is, the likelihood that the eggs are genetically abnormal or there are fewer genetically normal eggs. And so the chances of success from one IVF cycle decrease, but with multiple IVF cycles, there is still a very good chance of success depending on their egg reserve. And that's it. So this is our group here in the Center for Reproductive Medicine, Orlando, and we're here to help.
Wonderful. This is very insightful. Thank you very much, Dr. Sadek. We have a couple of questions. The first one, can you please?
Irina, can I just talk a little bit about the psychological aspects?
Absolutely,
So,
Dr. Delmar.
But actually, I have one quick question. I knew that obesity was linked to male factor. I didn't know that bariatric surgery was also linked to male factor. What about the new drugs that people are using for weight loss, like Wegovy?
We don't have any data on it, or at least I haven't seen any good data on it. With bariatric surgery, I think there's a disruption in the HPA axis, so the signal between the brain and the testes to produce sperm. I think what happens similar in women is when there's a significant amount of weight loss, the body goes into starvation mode, and reproductive fertility may not be as important during that time. But typically what I've seen is it does recover. Sometimes it may need assistance from a reproductive urologist, but it does recover.
Thank you. Do you mind stop sharing?
Oh, yes, absolutely.
Thank you. Just so I don't look like this odd voice. So I just want to talk just for a couple of minutes about the psychological aspects of male factor. And, it's probably the least talked about in terms of all of infertility, because a lot of men associate, sperm with, masculinity and virility and being a man and things like that. And so for a lot of couples, if it's a male factor, the male partner may not want his wife or partner to tell anybody what their diagnosis is. And so in a lot of cases of male factor, the assumption is always it's a female factor. And I think in our society, we very frequently blame the woman. And we may have this, assumption that it's always due to a woman's issue. And as you said earlier, it's just as likely to be a male factor as a female factor. And, I think for a lot of men, they just don't want anyone to know. And so, as you mentioned, most of the time for a male factor, you in effect take a reproductively healthy woman and turn her into the patient. And so this can cause some issues with the couple because, she has to take medication, she might have to do an egg retrieval, etc. And he may feel very guilty that because of his physical problem of male factor fertility issues, his wife has turned into a patient. And so I've seen lots and lots of couples where it's a male factor and, they're doing an IVF cycle so they can do ICSI to inject one sperm into each egg. And the husband or the male partner has a really hard time watching his wife have to do shots every day and go in for monitoring, et cetera, et cetera. And that can cause some conflict within the couple because a lot of men, when they're feeling guilty or shame, they often will pull back. And the woman might feel unhappy that she has to be a patient. And so I'd say if you are experiencing male factor infertility and there's any strain between the two of you, and this is probably more common than not, it's a good idea to seek out a reproductive mental health professional. And if you're seeing an infertility doctor, I can guarantee you they know somebody who they refer patients to. And if not, if you go to asrm.org, so it's the American Society for Reproductive Medicine.org, there's a whole list of mental health professionals in the country who specialize in this kind of counseling. And I've seen lots of couples where there's a male factor and they just didn't really know how to communicate about it. And it's always, even if you could just go for one session so you can learn communication and coping, et cetera, because it can put a strain. It's a hard thing to go through. So that's all I have to say, but I'm happy to take questions. I actually like questions. So Irina, do you want to launch into the questions that have come in?
Absolutely. So we have a few questions. The first one for Dr. Static. Can you please elaborate on invasive retrieval of sperm procedures? When is it required and at what level it is required?
So retrieval of sperm is usually called either a TESSI or a TESSA or a PESA. Basically, it's aspirating sperm from the testes or sometimes even getting a biopsy from the sperm. It's usually needed in two main situations: when there's no sperm in the ejaculate, or if the patient has had a vasectomy and is either had a vasectomy reversal that didn't work, or doesn't want to do a vasectomy reversal and just wants to do a testicular biopsy. Those are the two main situations. Occasionally, when there's a very few amount of sperm in the ejaculate, and let's say they've gone through IVF and it hasn't worked, sometimes we recommend at that point doing a testicular biopsy because we have seen we get better results if we obtain sperm from the testes compared from the ejaculate.
Thank you very much. Dr. Delmar, I do have a question for you. How can couple emotionally cope with male infertility? Any advice that you can offer to couples?
As I said, I think infertility causes strain in all relationships because, I've been doing this for 30 something years and I have never seen a couple where both members of the couple were in the same place and at the same time. And so, when male factor is diagnosed, the female partner, for example, and this is what I see most often, wants to go straight to IVF ICSI because that is the fastest route to having a baby. And the male partner may be hesitant and they may want to try, timed relations with letrozole or, try IUI. And, a lot of men don't even want to have sperm counts. I can't tell you how many patients I've had that we couldn't move ahead with treatment for them because their partner refused to come in for a semen analysis. And I think you just have to approach this as a unit. you are trying to create a family together. And whoever carries a diagnosis, or if you both carry a diagnosis, I mean, I was actually seeing a new patient today, and it was both members of the couple. And, I said to them, you're kind of lucky that both of you have an infertility diagnosis. And in effect, you're both subfertile because they could share in the experience more. I think if it's just female factor, because the women receive the treatment, the attention and intensity is for her. And if it's male factor, as I said, a lot of men, when they're upset, they tend to withdraw at a time when their partner really needs the support. So, I really recommend just talking to someone like me once, just so people can vent. You often hear from couples going through infertility that the female partner in a heterosexual couple, the female partner wants to talk about it a lot and the man does not. And I think this is especially true with male factor because, it's her body and she wants to talk about it, and all her friends are getting pregnant, and all her coworkers are getting pregnant, and all her siblings are getting pregnant. And so she wants to talk about how hard this is for her. And he's feeling really guilty that they have infertility because of him. And so he doesn't want to talk about it. And so that can cause an issue because she needs a chance to vent. And I think he needs to understand that, women tend to be more emotive anyway. And they just need to support each other. It's a crisis. The pregnancy rates for male factor are terrific with IVF and ICSI. And so if you can move on to IVF and ICSI, I'm sure Dr. Sadek would say the same thing. There's a really good chance you're going to have a baby.
Wonderful, thank you. And Dr. Delmar, next question for you as well. When patients receiving news that is different from what they were expecting, any recommendations on how to cope with the time of negative news or not the news that they were expecting?
Unfortunately, in this field, it happens a lot. Because when you're doing your workup and starting treatment, whose ever diagnosis it is, and, honestly, I think it's better for everyone involved if both of you have some kind of diagnosis so that one partner doesn't feel like they're causing the infertility. I think it's a good opportunity to learn coping strategies and how to communicate during a crisis. The data actually shows that couples who've gone through infertility have lower divorce rates than couples who have children. I think because you learn very quickly that you need to talk about these things. You need to work out. People have different coping strategies. As I said, women want to talk about it more. Men tend to want to talk about it less. And she might need to get support elsewhere. And so, I saw this new couple today and, she's feeling very isolated and she feels she's not getting enough support. And I said, I think for a lot of couples going through infertility, she needs to talk to other women who are going through infertility. I wish I could say that there are support groups for men all over the US and Canada, but there aren't. I have tried many times to launch support groups for men, and it's really hard to get men to agree to participate. But, in the Mind Body program that I used to offer, the 10-session program, women came to all 10 sessions and the men came to 3 of them. And one of the sessions, we would have the men go off and talk to a therapist, just like, 10 or 12 or 15 men. And it was just so interesting to hear them talk very honestly without their partner present. And how many of them said, this is really hard for me, but I have to stay strong because one of us, if both of us fall apart, what's going to happen to us? And so they have to put on this, very brave front when they are crying inside. They also may not know how to deal with their wife being this upset, and getting a negative pregnancy test is a true crisis.
Thank you. Dr. Sadek, I have a question for you next. How often sperm regenerate?
So it takes about 60 to 90 days for a sperm to generate from the testes and be released into the seminal tract or the reproductive tract. And so it takes about 60 to 90 days for any effect to be kind of removed also. So if you're smoking, that can last 60 to 90 days in your sperm. If you're doing any illicit drugs like marijuana, that can take 60 to 90 days to be removed from the sperm. And so that's how long the sperm can take to regenerate.
So basically, if patient were tested low sperm count after 90 days, if they're improving the lifestyle, there are a possibility that
Yeah.
the sperm quality will improve.
Yeah, absolutely. However, with stuff like testosterone and other anabolic steroids, even though the sperm it should regenerate within 60 to 90 days, it can take up to a year to see any sperm in the sample.
So one thing I would say is that if the male partner is taking anabolic steroids and hasn't told their female partner, this is a good time to fess up. Because I've had patients who, had a whole workup and they saw a male factor and no one could understand why. And then the doctor would somehow get the man alone in the room and ask specifically, are you taking steroids? And the man would say, yes, I am, but I don't want my wife to know. So if you are taking steroids, you do need to fess up.
Interesting.
Yeah, that's usually a good time to ask that question.
Yeah.
Good. Another question we have, does frequent cycling impact sperm quality?
It shouldn't. I'm not aware of any data that shows that it does, but I don't think it should. Any exercising should help. However, anything that increases the temperature of the sperm may affect the sperm count, but exercising shouldn't.
Okay. And how does age affect male fertility? We all know that with females, the older you are, your egg count drastically decrease. How about male, if you can answer that?
For men above the age of 40 or 45, the sperm count starts to be affected. How fast they're moving, the DNA integrity of the sperm also starts to be affected. For men above the age of 45, there's a higher risk of miscarriage in the female partner due to a sperm factor. And there's a higher chance of the embryo being abnormal due to the sperm factor. That being said, it's still only 10% of the factors that affect the sperm. The female age is the biggest factor, and that causes 90% of the abnormal embryo.
Excellent, thank you. And the last question that we have today is, when should couples consider using a donor sperm?
So using a donor sperm it can be brought up at different points in the treatment for couples. If it's a same-sex couple, obviously that is one of the first treatment options. But if it's a heterosexual couple, then if there have been multiple attempts with IVF with the partner's sperm and it hasn't worked, or if there's no sperm in the ejaculate and we can't get sperm on the biopsy, that is another time point where donor sperm is an option. But also, if we feel like the embryo quality is being affected by the sperm, then that is also another time point or a discussion point where we bring up donor sperm.
Thank you. I'm sure it's very hard news to deliver to the patient to consider those routes, but there are opportunities and different options for a couple. So thank you for elaborating on that question.
Can I just
Absolutely.
add one thing in a couple who is contemplating using donor sperm, the long-term research on the relationship between the child from donor sperm and their dad is really good. That the father-child relationship is, in fact, one study was better than in men who had children with their own sperm. So there can still be a wonderful parent-child a father-child relationship.
Thank you, Dr. Delmar. And I would like to open our floor for both of you. If there are any closing remarks that you would like to share with our patients who join us for this webinar today, that would be great.
Dr. Sadek, do you have anything you want to add?
The only thing I want to say is don't wait to get your fertility checked. The longer you wait, the less likelihood of success, especially as we get older. So If you meet that marks of the 1 year of trying to conceive, and if you haven't been able to get pregnant, if you meet that 6 months mark above the age of 35, go see a reproductive endocrinologist or fertility physician, just so you can get the testing and figure out if there's anything going on.
And I would add, I think, you know, the World Health Organization a number of years ago classified infertility as a disease. And so if you have male factor infertility or your partner has male factor infertility, it doesn't make them less of a man. It doesn't make them less masculine. It doesn't make them less virile. It has nothing to do with sexual ability or prowess. It's a disease. And just like with any other disease, you're going to go see a physician to get it treated. That's the exact same thing. That you have to think of male factor infertility in that exact same way. You have male factor, go see an infertility doctor, get treated, and very good chance you'll have a healthy baby.
Thank you. I appreciate both of you joining for the webinar today and sharing those insights with the patients. Thank you once again. Please do not hesitate to submit your questions afterwards. If you have any, we'll be happy to address them. Thank you once again.
Thanks, Irina. Bye.
Thank you.
Goodbye.